Welcome. I'm Christine Basilar, Director of Business Development for the Western Region with Rogers Behavioral Health, and I am your moderator. Joining me today for the second webinar in the two-part series on treating mental health and addiction during COVID-19 are Dr. Sean LeNoue, an addiction psychiatrist based at Rogers Nashville location, and Dr. Michelle Maloney, the Executive Director of Addiction Recovery Services at Rogers. Unfortunately, one of last week's presenters, Dr. Gabrielle Jones, is out for the next 2 weeks on a medical leave. We appreciate your understanding of this sudden change and thank Dr. LeNoue for covering her portion of the presentation. Before we get started, I wanted to give a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. To receive CE credits, you must be logged into the webinar for the entire program. We are recording the webinar and will publish it on our website along with the PDF of the slides for you to rewatch at your convenience. However, please note that the CE credits will not be awarded for just watching. Drs. LeNoue and Maloney will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our presenters a question during this presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you would simply click on the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. Now I'll turn it over to the presenters.
Thanks so much, Christine. Hello, everyone. I'm Sean LeNoue, and it's good to be back for our second week of this two-part series of looking at treatment for mental health and co-occurring disorders in this time, particularly of COVID. And so I wanted to start with just an acknowledgement of a couple things. First and foremost being that Dr. Gabrielle Jones is not able to join us today. And we're wishing her certainly a speedy recovery. As she was due to provide expertise today and present and discuss diversity and thinking about vulnerable populations and being really mindful about providing informed care to all individuals needing services. And so I'm going to be filling in for her today, but certainly and admittedly, that is an area that we really wish that she could have been a part of, to be here, to be a part of the discussion and to present. So certainly I think an opportunity for her to join in the future. We know that the area of diversity is really an important one, and inclusivity is certainly important. So we want to always make sure that we're providing the safest, most informed, culturally sensitive, evidence-based care that we can to all individuals that we're working with. So one other thing before we jump in for today is that Dr. Maloney and I are going to be presenting on a number of different topics, and we certainly recognize that there was a lot of content last week. And so really the overall intent in this two-part series is for it to be fairly fluid and definitely going to have more time, much more time this week. We're planning to sit down and to talk and have more of an open, robust Q&A session. So certainly that is on our mind, and we want to do that. So without further ado, we'll get started here. As far as disclosures, same as last week, we don't have any disclosures, as you can see here. We'll move on to the next slide. So today we'll be looking at a number of things, but our three main objectives will be to, one, identify 3 ways that a patient's cultural background can impact their treatment and treatment outcomes. We'll also list 2 pharmacotherapeutic interventions for opioid use disorder that aligns with being able to treat during the limitations of COVID and thinking about evidence-based medicine. And then we'll also look to explain 2 ways to utilize telehealth to build community, especially for recovery and support community. So moving on, we're going to again look at first cultural implications that may impact treatment outcomes. So we're going to think about socioeconomic factors. We're going to look at access to care and cultural norms surrounding substance use, as well as thinking about vulnerable populations and how we can meet the need the needs of all individuals and making sure that we're being sensitive to the different needs of individuals. So then we're going to move into talking about pharmacotherapeutic interventions for the treatment of substance use disorders, and we'll think about logistics of providing safe, informed care, all virtually through telehealth, and we'll think about different treatment options, as well as addressing monitoring concerns for medication compliance and relapse prevention. And then Dr. Maloney is going to talk about utilizing telehealth, as I mentioned, to build community for recovery. So moving on, we'll start with cultural implications that may impact treatment outcomes. So to begin, we want to note that the following slides are general considerations, certainly based on research findings, and that these considerations may not always apply to every person who identifies with a specified subgroup. So more than anything else, what we just want to emphasize is the importance of mindfulness and openness and acceptance, and just trying to meet any individual where they're at, and trying to certainly learn more about their beliefs and their belief system if we're not as aware, and certainly educating ourselves to be the most mindful and informed as possible. So we'll start with thinking about awareness of cultural identity. And so, with regards to telehealth, this may require more detailed questions during assessment, and I think level setting and really trying to understand and being curious about, a person and their background and their identity and their belief system, because it's so important, and thinking about how we can meet that individual where they're at. And so being mindful of their background and their needs. And this can provide insight to other aspects of their substance use as well, when we think about different norms, as well as just frankly different stressors that affect us all, but maybe affect different people in different ways. And so making sure that we're trying to provide as tailored and individualized and specific and informed treatment as possible. We have to think about apprehensiveness to treatment, and thinking about if there are potential, implications that come into play with regard to cultural norms or different barriers to treatment, stigma that could come up. And so wanting to be very, very sensitive to the needs and apprehension that different individuals may have when it comes to treatment. And so, I think one of the best things that we can do in this case too is just, starting with some general open-ended questions and really trying to understand, what brings you in to treatment, and what are you wanting from this process and this experience, and how can we help to meet your needs? You are the expert of you and your life and your background. Help, really this work is very much based in it being a team effort, right? With each team member, the patient, individual, the client, the provider, bringing different things to the treatment and care, but really it's going to be a partnership, a professional partnership, no doubt, but thinking about, how do we engage the client, the patient, to inform us about their specific needs, their desires, their viewpoints, and how do we then tailor a treatment regimen that's very specific to those needs and those wants. We'll also think about the function of substance use behavior, which certainly we know can serve as a variety of different things, including self-medication, or, thinking about what is culturally normed versus not normed with regard to substance use within different subgroups and populations. And then we'll want to think about motivation for change, and just really, again, as always, being open-minded, accepting, and how can we help individuals to, create that motivation for change, to develop that insight and discrepancy and awareness, and helping them to achieve their goals. So moving on, then we'll look at background considerations as well. And again, these are from Dr. Jones's slides and her work. And so thinking about, she starts here and mentions African-American communities, thinking about psychosocial stressors that may come into play, and the role of racism, and how those factors can influence stress, no doubt, and thinking about the role of substance use and possible coping related to racism that may be sustained. And we want to think about pre-existing health conditions and disparities, as well, and thinking about not only, I think, when we think about racism and stigma, but also access to care, and thinking about making sure that we're doing all that we can to create access to care is always so important. And we want to think about, especially during this time too, during COVID, where we very much live in this isolated world and in this virtual world, where that really takes a toll on individuals. And I think that I think we know this sort of in theory, we're living it right now in many ways, but the ultimate effects and impacts, I think, are really still not totally clear, and we're learning more and more each and every day. And so we'll talk more about this in a bit later in this presentation, but thinking about how can we create community when it comes to recovery and support, but community in general, to allow, individuals, as humans, we are social creatures. And so how can we create community for interaction and engagement and support? Moving on, we'll think about Latin American communities and thinking about the broad set of communities that exist within this population, no doubt. And this certainly, a language barrier is not unique to this community, but certainly a factor that we always want to consider for this community and other communities as well. And thinking about the role of language and thinking about that way that we can communicate. It's so essential and so basic and so vitally important that we can communicate with one another. So, when there are barriers that come into play with being able to effectively convey a message, concerns, qualities, characteristics that someone may want to talk about themselves to better inform care, these are essential and so important. And so we'll want to think about, as always, reducing barriers, particularly in this case, language barriers. So thinking about, how can we overcome these obstacles? And luckily, we live in a fairly highly technical world. And so thinking about the use of interpreter translation services, I think, is going to be really important in making sure that we help individuals to be as comfortable and as open as possible, including speaking in their native language. This can certainly help with rapport building as well, no doubt, and thinking about the clinician, the provider's own comprehension and understanding of the various facets and stressors and strengths, frankly, that come into play and that affect an individual. And then when we think about formulation of a treatment plan and how we can meet them where they're at and meet their needs, that's going to be vitally important too. The cohesion piece, I think this is certainly a reiteration of another, of this very important point of just developing that rapport and being able to work in a cohesive manner with your client or patient. We'll think about here in this community in particular, and others, kind of thinking about gender roles, certainly, and no doubt, the role of substance use, and if that is, more unique or specific to some populations more than others. There's a great degree of variability, no doubt. But again, I think this just goes back more than anything else to just wanting to understand an individual, to meet them where they're at, and to connect with them and to help them during their time of need. And again, thinking about lack of community and isolation. So we'll move on and look at the Native American community and population, and we'll think about norms here too when we think about possible, ceremonial use of different substances, as well as the role of community and bonding and connection, spirituality, and how that may come into play, and being sensitive and mindful to kind of the role that different substances may have in an individual's culture. We want to think about perception of risk, right? I'm a child psychiatrist and addiction psychiatrist, and so I always think about this too when we think about use, when we think about, perception of risk and harm that could come from substance use. And frankly, it may be lower depending on a different environment or norms. And so we never want to put a label, on anything as far as different cultures or communities' perception. And so not certainly trying to think about that as though it is something in a negative light, but again, trying to understand, what, is normed, and also understanding goals and understanding an individual and their perception in their goals of treatment and how these different factors may be affecting them. In particular, within this community, certainly we know that more research needs to be done. It needs to be done, across all groups and communities. But this community in particular, there are limitations with restrictions related to research on reservations, being individuals being misidentified culturally, ethnically, and so things to think about there. Moving on, we'll look at Asian American and think about Asian American communities, and certainly understanding that this, covers a very broad and diverse, different groups and communities of people, and thinking about how different cultural norms, while there can be parallels and overlap, there can also be, variability too. So thinking about the broad set of communities here, there's also less research noted, possibly, sometimes substance use could be due to holistic approach to treatment, or different things like that. And I think what's important to note too is while that may apply to this community, it certainly may apply to other communities as well. And so we also want to think about background and thinking about trust, because trust and rapport, as always, are so important. And we want to think about, an individual and a community's trust in a mental health system and their perception of what that system is aiming to provide, and how that system wants to help. So we'll think about variations in those communities to substance choice variations, cultural variations, and considerations there. When we think about substances identified in research, Dr. Jones notes here, in particular for this group, thinking about tobacco, cannabis, amphetamines, opioids, in many ways unique and not unique between this community and others. But again, I think it's always really, really important to know kind of, different facets of culture, and certainly different substances that may be more prominent to a different culture or community. So moving to our next slide, we'll think about sexual orientation considerations as well. And this is also very important. And so this is where we see that intersection between, race and gender minority. And so when we think about racial, ethnic, cultural groups, and then kind of the subgroup within these populations of sexual orientation, and there's certainly an increased risk for discrimination in individuals who may be in the minority. And so always, again, wanting to approach anyone and everyone that we're working with openly, and, asking about sexual orientation in a non-judgmental, open way, and this also goes into thinking about, gender identity as well, and thinking about preferred pronouns, and thinking about, a name that someone prefers to be called, as far as, first or last name. And so really trying to be as open as we can to the uniqueness and individual nature of us all, and helping people to be seen and to be heard. When we think about health disparities too, it's similar in this group to other communities depending on race and ethnicity overall. And again, Dr. Jones just mentions here, as always, it is so vitally important to treat the whole person, and taking into consideration the variety of different and various identities that make up, an individual. And we want to think about health factors certainly as a priority, and thinking about risk factors as well. Moving to our next slide, we will think about socioeconomic status considerations too, when we think about finances and job and access to healthcare, all really, really important. And thinking about lack of financial resources in order to receive treatment, right? Because if an individual is struggling to make ends meet, then it can be difficult for them to get to therapy or to treatment. It can be difficult for them to be able to afford treatment because they may or may not have insurance. And especially when we think about times of COVID right now, when unemployment is certainly up and job security can be quite uncertain. These are certainly factors that we want to think about and that are so important to address. And so we definitely want to think about too, are there ways to streamline treatment and care so that we're providing the most effective treatment as soon as possible, as quickly as possible, and in the most cost-effective way possible too. We'll think about, thinking about like obtaining drug screening. And so, does that person gonna have to go into a lab? Are they gonna be at home? What's the cost of testing? Is it covered by insurance? Something that we have done is provided salivary instant drug screen testing in order to allow individuals to, complete testing and screening from the safety security of their home in order to practice social distancing whenever appropriate and possible, and to also provide a way with as great of integrity as possible to ensure the validity of screening and testing. So that's certainly one thing that we can do. I think really that those are the main points that Dr. Jones had mentioned and wanted to discuss here. But again, just being ever mindful, especially during times of COVID and social distancing, of the way that individuals are impacted on a number of different levels. So we'll move on and think about living environment, which is so important too. It's always important, and especially now when people may be living in close quarters. And when we think about being able to provide telehealth services, this is, I think, a really wonderful technology, but there's a new set of parameters or circumstances and factors that come into play that maybe weren't issues before, or weren't as prominent of issues with in-person treatment and care. And so, family members need a place to stay, obviously. And so if you have numerous people in a space, or even at times in a small space, children who have been home from school, family members who may not be working or may be working on a limited basis, living in a space, that can be loud. It can be difficult to find a place to be able to speak in private. And so definitely, factors that we have had to troubleshoot and to try to problem solve during this process. Isolation, living alone, on the flip side, so being in isolation and not having as many people around, certainly we want to think there too about the risk for relapse, right? Because with less accountability, less contact with individuals and a recovery support community, it can become increasingly difficult, especially if someone's experiencing increased stress, increased anxiety, financial stressors. They may find the temptation to self-medicate is greater than ever. And so that's we're going to talk more in a bit too about how we can break down those barriers and to maintain community now more than ever. Homelessness also, going very much along with what we're discussing here, is also certainly a concern. And so, yeah, I think what we're really having to think about is, really, this has been a game changer, I think, for, members of society, patients, providers, in many ways, of just trying to create a great degree of flexibility, understanding, and trying to think outside of the box when it comes to treatment, delivery and care and access, and trying to be able to meet individuals where they're at. And there are not always clear or simple or easy solutions to very complicated scenarios and situations. So maintaining connectedness whenever and however appropriate and possible is so, so important. We'll move to the next slide here and think about, again, reiteration of employment status overall, negative impacts on recovery outcomes, more psychosocial stressors. And we see that, at times, treatment can become less of a priority. If you have an individual who's really struggling just to make ends meet, to take care of their family, to take care of themselves, keep the lights on, sadly, substance treatment, mental health treatment may not be a priority at all, or it may become less of a priority. So thinking definitely, we've had to think about ways that we can, in increasing access to care, think about not only delivery of care and services, but also thinking about community resources that we have within our organization and foundation, grant funding to be able to allow for individuals who need the help the most to be able to get the help that they need when they need it, even when circumstances are so trying. Educational level, Dr. Jones notes here about the potential for being a correlation between educational level and thinking about stressors. Certainly not causative, but certainly could be correlated, in thinking about jobs that may be at risk, and thinking about how it can be hard to find a job and maintain a job when businesses may or may not be hiring or having to lay individuals off. We've seen that geographic location has a large impact on the effect on patients. And telehealth, the good news can be helpful in cost reduction, right? So it could be less expensive than in-person visits, or there could be less cost associated with transportation, getting back and forth to treatment, or less time that is needed to be away from work. So definitely wanting to utilize, these opportunities whenever possible. We'll move next, again, transportation here. So important, thinking about funding for transportation. One of the things that we do oftentimes is for individuals who are really struggling. We think about, bus passes. We think about even, we have a Lyft account that we would be able to provide services to, if their car is broken down, or, they're having issues getting in for the day, to be able to provide at no cost to the patient or family, transportation to be able to come into treatment in order to reduce barriers. And Dr. Jones mentions here too, thinking about considerations for car sharing options and also technology. And so what we've done too is thinking about grant funding in order to provide individuals with a phone or a tablet, or in many cases we have laptops that we can loan out to families and individuals so that they can still connect through telehealth care services. Yeah. And I think next here, we'll see, Dr. Maloney looks like has popped on. Yeah.
Yeah, so, I think one of the things, certainly Dr. LeNoue, as we, take a look at vulnerable populations, but we also think about COVID. One of the things that we're seeing in emerging research, even this week, is that, substance use patients tend to be at more risk for COVID. And, that's really coming out of some recent research from both Harvard and the national academies. And it makes sense that, if they're smoking marijuana, smoking cigarettes, that it's a respiratory illness. And so there, has a certain impact on their lungs. But in addition to that, we're also seeing emerging research. There was a study that came out of Wisconsin that was just published this week that indicated that, Black patients who contracted COVID were 18 times more likely to die of COVID than Caucasian individuals that contract COVID. So I think this also becomes a consideration when we're working with, both substance use patients and COVID, in the midst of this pandemic. And as we look to other vulnerable populations and some possible solutions, Dr. LeNoue, as you mentioned throughout, what can we do within the company? We're a nonprofit, and we're very fortunate in many ways in that, if we do identify a need, how can we assist them? How can we work with some of our business partners in transportation vouchers or on the technology end? Can we alternate between in-person visits, virtual visits in substance use? Because particularly if we're concerned that individuals are relapsing, can we bring them into clinic and then the next one be on telehealth? Can we attempt to consolidate in-person visits? So, Dr. LeNoue, when they come into our clinic, you see them as the psychiatrist, we see them as the clinical, they attend group. Can we consolidate all their visits with the multidisciplinary team in that one visit? And then on an individual basis, maybe in an outpatient, engaging in case management with some of these patients may be a priority. As you mentioned, feeding their family or being able to feed themselves, engaging in, job searches or, trying to find recovery groups. I spend a lot of time right now helping patients engage in recovery support groups. And that not only helps them with their self-efficacy, but it also helps with recovery and relapse prevention. And so I think just continually looking at, it as a whole picture will continually be key, as we don't know if there's a second wave. We see in the news, COVID cases are rising. And what does that mean for the long term? I think is still anybody's guess at this moment. So, in summary of this section, overall, it's important for us to take cultural factors into consideration while engaging with, substance use patients, mental health patients, co-occurring patients with vulnerable populations.
Thank you so much, Dr. Maloney. So definitely, so taking that into account and into consideration, being ever mindful of those factors, now we're going to transition and move into our next section and talk about pharmacotherapeutic interventions for the treatment of substance use disorders. And so we'll jump right in and we'll think about general considerations. And, really, as always, and now more than ever, we really want to always start with a really thorough assessment of symptoms and issues and factors that are coming into play that are affecting an individual. And I definitely take a strengths-based approach in thinking about, what are obstacles that we're needing and wanting to overcome, but also, and there are oftentimes many, which is wonderful. What are the strengths that we have to play off of to help an individual to achieve their goal of recovery and maintaining recovery? So, another key factor is we want to think about motivation for treatment and change. There are no right or wrong answers here, but we just want to really try to understand what is driving an individual to make this change now, right? And so again, to the next point, why now? What is it about this time versus a month ago versus a year from now that an individual is reaching out, asking for help, seeking treatment, and looking to create change? Because change can be wonderful, can also be really tough, right? So we want to assess what is driving that motivation for change. As well, we'll think about, as a driver, is this person coming to seek help on a voluntary basis? Is this court ordered or mandated versus, a spouse or a loved one that may or may not be, providing some pressure, or even at times we see and hear an ultimatum, this is really impacting the marriage, the relationship. This is in fact, it's really, it can be quite negatively impactful, not only on the individual struggling, but also on children, other family members, things like that. So that's going to be really important to understand too, again, when we think about motivation. We definitely want to think about risk factors for relapse. And we've talked about many during this time of COVID, with isolation, with the stress that comes from a variety of different, psychosocial issues, the uncertainty of the times, finances, jobs, so on and so forth. Definitely want to think about level of care, right? We provide telehealth care services at a variety of different levels of care, especially in our partial hospitalization and intensive outpatient levels of care. But really thinking about, this as an opportunity in being able to support an individual, and what would be the most appropriate level to provide that support and structure and accountability. And, then we'll think about treating mental health and substance use disorders concurrently. And I think, this is so important that we have seen clearly in the research and literature, but also clinically as well, that these issues, mental health issues, stressors, sleep issues, substance use, they don't exist in silos, right? And so they affect one another. How could they not? And so when we are creating, a culturally informed, individually tailored treatment regimen, we definitely want to think about how are we going to be incorporating treatment support for a variety of different factors coming into play, including mental health, substance use treatment, medical treatment and support, in addition to, and we'll talk a little bit here about, family support and different psychotherapeutic modalities. So we'll move into the next slide and we will think about, again, with considerations here, thinking about the role that stigma plays, not only in mental health treatment, awareness, support, but especially with substance use and substance treatment. And then thinking about, as we discussed earlier too, the different cultural factors that could come into play when we think about stigma. And again, we want to think about planning for long-term recovery. We need to help an individual to achieve and maintain sobriety in the here and now today, but also what is our long-term plan? And if we're only thinking about one versus the other, then maybe we're not thinking about as robust of a plan as possible. And I think leading into this final point here, definitely the role of community is so important, because again, when we think about cultural factors, when we think about accountability, when we think about support, when we think about the ways that individuals may derive joy in that social connectedness within their community, and community exists in so many different ways, and so definitely going back to that strengths-based approach, looking for ways to build and foster and tap into community supports is definitely very important. So we'll move into the next section and think about treatment of different substance use disorders. And as always, after we've done a thorough assessment, we definitely want to start with psychotherapy, right? Being really the foundation of the work that we do in helping to create motivation for change, working on developing insight, and evidence-based treatment options here for therapy include cognitive behavioral therapy and CBT, as well as dialectical behavioral therapy, and thinking about core components of working on developing mindfulness, distress tolerance, emotional regulation, being able to help an individual to effectively communicate. And when we think about different family dynamics and factors that can come into play, communication is always really important, and we want to definitely make sure that we're able to utilize communication as a strength and try to reduce any barriers to communication. And sometimes that's really tough. But also, I think in doing this work, especially with family therapy work, we definitely try to reduce those barriers. We try to help individuals to look for commonality and to try to see eye to eye whenever possible with different family members, trying to understand the past and history, but also with the real goal and intention of looking to the future and how we can help individuals and families to come together and to build off of those strengths. And along with that, kind of tied in certainly is motivational interviewing, right? Which we rely heavily upon. And not only for the client or the patient that we're working with, but also oftentimes it can come up within family systems and family dynamics, because again, these issues typically do not exist in silos, and so there can certainly be family history of substance use, and maybe individuals who are using in the home. And as Dr. Jones talked about last week, thinking about when we're trying to help an individual who may be in isolation because of COVID, who is living, possibly in close proximity with others in the home, and that the identified client or patient is trying to work on recovery, and there may be other people in the home who may be using substances and they may not be in that same state of change as our client. And so then thinking about how do we address those issues effectively to support our client, our patient, and also to respect the family and the family system, and also to come together to create support and to drive change in a positive way. Contingency management is another really important factor that we always try to utilize whenever possible, with the key component here really being positive reinforcement for pro-social behaviors, for engaging in treatment, for engaging in positive, healthy self-care, really trying to reward those behaviors that we're wanting to see to help someone, again, achieve and maintain recovery. And 12-step facilitation is certainly another key pillar that we lean heavily upon. Certainly this is not the only modality that we can utilize, but definitely thinking about a system of support and recovery, and thinking about helping individuals to work through this process in the here and now today, but also, with a long-term plan, and giving individuals a framework for recovery that we really try to bring together through all of these different modalities. So we'll move into our next slide and then think about when and if it would possibly be appropriate to utilize recovery medications. And so certainly it is not a one-size-fits-all approach. And there are a number of indications where recovery medications may be warranted, after you have a really in-depth and thorough conversation to inform your client, your patient, about risks and benefits, pros and cons, alternatives. But in cases where we're seeing more moderate to severe substance use that is, significantly and negatively impacting quality of life, functioning, health, general well-being, we do sometimes think about the role of recovery medications. And I would say nearly always, I can't really think of a situation where we would not recommend that. Definitely, if we're going to think about medications, that we would utilize this tool of medications to be done in conjunction with really intensive psychotherapy services, which it's the gold standard for more moderate to severe symptoms and treatment, to utilize medications in conjunction, side by side with intensive psychotherapy. So FDA approved medications, which we're going to talk about here in a moment, there are medications that exist for the treatment of alcohol use disorder, as well as opioid use disorder, and tobacco or nicotine use. So we'll jump right in. When we think about alcohol use disorder, current indications include naltrexone, which is a mu opioid receptor antagonist. So it's an opioid receptor blocker, really aiming to reduce the release, doesn't totally block, but certainly modulates dopamine, that feel-good neurotransmitter that's associated with cravings and urges to use and substance use. So, this medication has an indication for the treatment of alcohol use disorder in conjunction with psychotherapy. It exists in both an oral, shorter acting formulation, or a long acting injectable formulation that allows for individuals to go to a clinic once a month and to receive an injection. It's an intramuscular injection in the gluteus that then they only have to go in once a month every 28, 30 days. And to get that injection, then they don't have to then they don't have to take medication on a daily basis. For convenience, and if that's a concern of medication compliance, that's an option we have. Acamprosate is also an option that reduces cravings as well. It works through a bit of a different pathway, modulating the GABA receptor and an NMDA receptor. This, can be helpful. It's been hypothesized. There've been a number of studies, including a German study that's looked at the differences, the similarities and differences between acamprosate, naltrexone, and how they affect urges and cravings in reducing use. This also can be an effective treatment option. One downside is that it has to be dosed 3 times a day. So kind of morning, midday, and then in the evening or afternoon. And so that's something to be mindful of. It's certainly an option. Naltrexone is predominantly metabolized through the liver, whereas acamprosate is predominantly excreted through the kidneys. And so, if you have someone who is either on a variety of different medications that could have potential interactions with naltrexone, and or someone who has, more moderate to severe hepatitis, or an end stage, liver disease where maybe naltrexone wouldn't be warranted, acamprosate could be an alternative. Disulfiram is another medication that we sometimes think about and use. To be honest with you, it's certainly a medication that I have used when other options weren't available, but it's typically not one that I go to quite as much, really because of the way that this medication works and is designed is it inhibits an enzyme in the liver that breaks down alcohol. And so what it does is it can produce a pretty significant hangover reaction response when someone consumes alcohol or is exposed to different types of alcohol in different forms. And so certainly it is an option when other options aren't available, but typically is not as much of a go-to option for first line. Moving on, we will look at opioid use disorder, and we'll think about evidence-based options here. Again, naltrexone that we talked about with alcohol use disorder also has an indication for the treatment of opioid use disorder to reduce cravings and use. Again, blocking the opioid receptor here, it's just important to note that, depending on the type of opioid use that someone may be struggling with, we just need to be very mindful about, if we're thinking about naltrexone as being a treatment option, about the type of opioids that they've been using, whether they're long or shorter acting opioids, and proximity to last use, because when we start naltrexone, there certainly can be a risk of creating precipitated withdrawal or putting someone into opioid withdrawal if they still have opioids in their system. So, again, thorough evaluation and assessment, providing education, talking about risks and benefits, educating and providing informed consent, and receiving consent regarding the risk of precipitated withdrawal. And then we would look at, an instant drug screen testing as well to ensure if there is question, and it's our standard practice that we would utilize drug screen testing on the day of initiation of naltrexone to ensure that opioids are not in their system to reduce that chance or risk. Buprenorphine is also an option, and so this is a partial opioid receptor agonist. So it binds the opioid receptor, partially blocks and partially stimulates the receptor. It's been around for several decades, and it comes in both an oral sublingual form, or there is an implantable rod. And more recently, there is another long-acting form that allows for injection once monthly, and it's sort of a viscous substance that has a slow release over the course of 28 days, where an individual only has, just like with long-acting injectable naltrexone, so too do we now have that as an option for buprenorphine. And so that is an option, especially with more moderate to severe opioid use disorder, for individuals who maybe have failed antagonist treatment or therapy or other modalities, who are really struggling with relapse. That is certainly an option that we can look at. Methadone is also another option that has been around since World War II, and that is a full receptor agonist. So definitely what we need to think about with buprenorphine and methadone are certainly abuse potential, and then also risk for overdose. So things to think about and be mindful of there. We're going to keep moving for the sake of time. Tobacco nicotine use disorder, we have nicotine replacement options through patch, gums, lozenges, and inhalers. Also, bupropion has an indication to reduce cravings and use, and that's through its impact and effect on the nicotinic receptor. And then varenicline is another option that is quite effective. We just need to be mindful of here the risk for pretty intense, vivid dreams, as well as safety indications. And there's a black box warning. So definitely thinking about individuals' risk at baseline for mood, anxiety, safety concerns that could be coming up in the form of suicidality. Just wanted to do a thorough assessment, as always, for individuals that you may be considering for varenicline. We'll move on and we'll think about recovery medication. So no, again, continuing this conversation, no current FDA approved medications for cannabis use disorder, for stimulant or amphetamine use disorder, or for, again, amphetamine or cocaine. There are certainly medications that are being studied, including even vaccinations that are in trial to look at, reducing the impact and effect of these substances, but at this time, no current medication options that are FDA approved. Yeah.
Dr. LeNoue, you talked about recovery medications and the combination of recovery medications and intensive therapy really being that gold standard. And we've seen a lot of research based on that. So I'm wondering if you have any insight into some of the research that we see that recovery medications are used like less than 40% of the time, and there's such a shortage of waivered physicians. I'm wondering if you could give us some insight and speak a little bit about that.
Yeah, great question. Thank you, Dr. Maloney. I mean, I think it's multifaceted, that phenomenon that we see. I think that clearly education and educating patients, different community members, even providers at times, about the role and evidence base of recovery medications for specific individuals under specific circumstances. It's not a one-size-fits-all approach, but I think that educating about the safety of these medications overall, and certainly they need to be closely monitored by a trained provider, but that overall, when we think about relapse prevention and recovery, that these medications can be quite helpful. And oftentimes there can be stigma associated with these medications, and sort of a thought or philosophy that well, we're just replacing one drug for another, which we know is not true. And also that when we think about kind of the role, if we were to liken this to other medical issues like insulin, for example, with diabetes, if there's insulin dysregulation, glucose metabolism dysregulation, thinking about the way that we can provide and supplement in order to create homeostasis and balance for an individual with diabetes, so too is the philosophy and the approach for substance use disorders, especially with more agonist-based therapy. Again, I mentioned stigma, also guilt and shame that may come into play. And to your other point, Dr. Maloney, thinking about X-waiver providers and how there are a limited number of providers overall. The X waiver comes from the Data 2000 Act, and essentially is a waiver training that's required for certain types of practitioners in order to be able to prescribe buprenorphine for the treatment of opioid use disorder. And so there are a number of hours of training that are required in order to receive this waiver. And I guess certainly this is not an original thought or argument that I would make here. Certainly it's been well published, documented, discussed, but I think that act and the creation of the waiver system was certainly well intentioned, and there are many positives to it, but there may also be unintended consequences in limiting access to care and creating more barriers to be able to utilize these life-saving medications when they're appropriate and being monitored closely. So something to consider there, especially when their waivers are not required for prescribers to be able to provide patients when it's appropriate with, opioids, for example, or benzodiazepines or other controlled substances. So sort of asking the question about, are these limitations that have been put in place, are there unintended consequences to them? So how could we still maintain safety, regulations, accountability, no doubt, for providers and to create safety for our patients, but also to broaden access to care is certainly something that we always want to have a discussion about. And so thinking about long-term outcomes, to your point, Dr. Maloney, we're going to move into our next slide and think about, you know, in a few slides here, we'll talk about what the data shows. So monitoring for success, we're going to take a quick pause and kind of talk about drug screen testing, right? And really our approach and aim is to always utilize drug screen testing as a way to monitor for success. And there's a variety of different modalities that you can use for testing that we've talked about, and also thinking about rewarding negative drug screens and really seeing as an opportunity in screening for, you know, someone who's working really hard and putting their sobriety first. So that's kind of the aim that we go after. We're not trying to police individuals, but we are trying to provide safe and informed care. Yep. So we'll move on to the next slide and think about you know, duration of medication treatment. So when we're utilizing recovery medications, you know, how long do we utilize these medications? Well, it's an important and interesting question and has a bit of a complicated answer in some ways and not in others. I mean, really overall it comes down to key components of you know, risk-benefit analysis, so the risk of being on the medication compared to not, and the risk of relapse if someone is, you know, not on medication, or if they've tried other options that have not been successful. And really this is a graphic from a paper that came out a few years ago looking at long-term outcomes for individuals who were using opioids. And really what they've done here is this is sort of a group quantitative sort of risk stratified metric here that they've looked at, where, you know, on the x-axis we have months after enrollment in treatment, y-axis number of days of opioid use over 55 months. And what we see is that overall in that low use group, that one of the predominant features that came out is that there was a significant number of individuals, especially significant compared to these other groups where we saw ongoing high amounts of opioid use after enrolling in treatment, that those individuals with low or no use were individuals that were either taking methadone or buprenorphine. And so certainly that is, you know, those medications prescribed in conjunction with comprehensive psychotherapy services and support services, but just really trying to acknowledge that in more moderate to severe cases of substance use disorders, that the use of medications can be profound and quite helpful. So we'll move on and think about next about, you know, this is from TIP, the Treatment Improvement Protocol, from SAMHSA, the Substance Abuse and Mental Health Services Administration. You know, their most recent tip that they actually state that patients should take buprenorphine as long as they benefit from the medication and wish to continue. And clearly that is their decision as far as whether they want to take the medication or not, or whether they want to continue on it or not. And we always honor that. But we're always trying to think too and be mindful about the risk of providing an intervention and treatment versus not. And again, just overall noting that this is a neurobiologically based medical illness, addiction, substance use disorders are, and that, you know, we really want to treat them as such and be able to provide any and all safe, appropriate, evidence-based treatment options. So we'll keep going for the sake of time. And lastly, we'll just talk about, again, the importance of treating co-occurring issues here that I have noted. So we're gonna move on to our next slide, and I believe turn it over here to Dr. Maloney.
Dr. LeNoue. You know, Dr. LeNoue, as you mentioned, that addiction, you know, equates to isolation, and recovery really does equate to connection. And we've heard that adage over and over again during this pandemic. And so we really want to think about building connection, building communities, and, you know, depending on your theoretical and philosophical background, there are numerous definitions for recovery, just the word recovery. And the same really holds true for, the term community. Each patient that I've encountered during this time really has a different definition of community. And I have been inspired by, each of my patients as to how they've embraced community at times and the various things they're doing to achieve community. And so for the next section, we're really going to focus on kind of those traditional community-based meetings, 12 steps, smart recovery, celebrate recovery. But before we get there, there has been research done on virtual community meetings. There was a study done in 2017 that showed 2/3 of all adults engage in some form of social network, such as Facebook or Twitter, LinkedIn. And I'm guessing that if we were to do that study now, we'd see an increased use. But what kind of surprised me about this was, 65 and older were at a 35% engagement. And so, that was kind of a surprising to me. But really, previous research showed that these sites could enhance behavior change, and the focus was on smoking in that study. And then there was another 2017 study done on intherooms.com, which really does offer online meetings. And in the rooms is 67% are based on 12-step philosophy that focus on substance use. They have speaker tapes of individuals sharing inspirational messages. They have daily meditations, discussion boards, and again, some of the the demographics that they found on In the Rooms, the average age was 50.8 years old. They were female and they were Caucasian. And participation that they found during this study was evenly divided between once or twice a month, several times a week, and once a week for about 30 minutes per day. And then they looked at the impact of abstinence, and individuals, they defined abstinence as individuals greater than 1 year. And what they found with that was those individuals who had abstinence over 1 year were also involved in other 12-step organizations that were not related to AA or NA, but that they enhanced it with like Al-Anon. And so I did find that to be an interesting part, because we certainly know as part of long-term recovery, many of our patients also have family members who have suffered substance use or mental health as well. And so, when we look at COVID, we look at the pandemic and we think about it as being an opportunity, and sort of our glass half full, if you will, during this time, so that we can all keep our sanity, really looking at that rapid utilization of creating a support community. And some of the opportunities we found is it has allowed some of our patients who are in those early stages of change that you talked about, maybe those pre-contemplative, contemplative, even preparation, to explore different types of meetings. And they've been able to try the different types of meetings like Smart Recovery or 12-Step, because sometimes, I've run into patients who have had negative connotations or negative perceptions. And so it's been a struggle to get them to go to in-person meetings. It's also provided opportunities for individuals to attend meetings that maybe don't have the transportation. And so they've been able to, also try early morning meetings versus noon meetings versus evening meetings. And just again, to explore options. In addition, we treat a lot of patients with social anxiety, and it has given us an opportunity for some of our patients to also participate almost anonymously and to utilize an exposure technique within our treatment. And so as part of our treatment, maybe exposing them to a community-based meeting, again, in an effort to help them begin to build that sense of community. And so we look at some of these early efficacy studies that are coming out and, that were even done prior to COVID. And what do the online meetings do? Do they provide some efficacy? And there was, we found several studies, including a most recent 2020 study that really showed the key elements individuals were seeking, particularly if they were contemplating change or they didn't have the ability to get treatment. It allowed particularly for those individuals to try new things and to enhance their recovery. We also found receiving more emotional support was associated with reduced illicit drug use at both 6 and 12 months as part of the study. And really for those with low self-efficacy, giving more emotional support predicted less risky drinking at the 12-month mark. And so, we have found that virtual meetings do provide some efficacy. However, with, all of those good things, there are certainly challenges to online meetings. Clubhouses or, the recovery centers offer more than just that meeting. They offer a place for people to be. Sometimes it's a place to hang out. It provides a sense of family. And so when those closed, it really had a significant impact on a lot of recovering individuals. And there was kind of that no ability to socialize or connect with peers, that meeting after the meeting that really increased that socialization. That inability to be fully present. I mean, how many times where we've even been participating in a webinar or, something else that's going on with us and we've multitasked, so, are we fully present in attending the meeting, and our patients share the same thing. And so, there was a study put out over the past couple of weeks from the Addiction Policy Forum that really, surveyed 1,100 respondents. And what they found was that doing online meetings was not the same thing as going to a meeting. At the same time, 48% of those respondents reported a fear of contracting COVID as their top concern, even more so than social isolation. And one of the other things just to be aware of and cognizant of is that other addictive behaviors could potentially start with the online, such as internet and gaming. And in fact, there was a 2020 study that was done during this COVID time that found that internet addiction increased from 3.5% to 23% during this time frame. So it is something just to be cognizant of if your patient has that in their background. But as I mentioned, I'm really inspired by some of our patients and their opportunity to seek out support and their own definition of support. And so part of it is to think outside the box and how can your client, connect with others, because that's really what it's about. For some, it's about being a good neighbor. I had several patients share with me that they volunteered to read to children online. Some have offered to pick up groceries for some of their neighbors. Some have taken the opportunity to explore different faith-based meetings. And so what connections can you encourage with your patients, and what can you expose them to? What can they be exposed to as part of your therapeutic sessions with them? And we do have numerous, we strongly encourage recovery apps, and we have several that we're going to share with you today, anywhere from some that are free to some that cost a nominal amount. But really, how can your individual, how can your patient increase their sense of connection? And it may be different based on their culture, based on if they're single and living alone, or, based on there's multi-generationals living in one household. Everyone has that different definition of recovery. Everyone has that different definition of connection, and how can we bring them together. So, 5 key takeaways that we want to leave you with today before we go to our question and answer is, consider adjusting your approach to meet the needs of your patient, because this is a challenging time. It's a challenging time for our patients. It's a challenging time, for us as providers. Conduct in-depth assessments to ensure you're treating the whole person. Maybe an assessment previously took an hour. Maybe this time it'll take an hour and a half. The consideration of recovery medications, they may be appropriate for some of their patients. And combining that with the psychotherapy, the skills building concurrently with that recovery medications. Drug screening should be viewed as monitoring for success, really looking at that as an opportunity to even praise patients for having a negative urine, or a chance to relook at the treatment plan if it is positive. And then lastly, involvement in recovery support meetings remain a critical component to treatment and recovery, however your patient defines recovery or community. And to really, continually embrace the need for connection. And as I mentioned, here are some resources for some online meetings for AA that individuals can utilize. And I know we'll be happy to share this with you. And then lastly, here are some recovery apps that we have used with our patients and that our patients really have found valuable, particularly during this time. And so with that, I will open it up for questions.
Thank you. So if you do have questions, please use the Q&A button, not the chat feature, on the Zoom taskbar at the bottom, and we'll try to answer as many as we can in the time we have left. So our first question is, can you say more about PTSS, or post-traumatic slave syndrome?
PTSS was, it was a topic that Dr. Jones had included in the presentation, and really I think that whomever would like to discuss that, we certainly would happy to discuss that more, but we want to get you in touch with Dr. Jones to provide more expertise in how it applies both socially, culturally, and then clinically, if at all. So certainly, I think definitely wanting to put you in touch with the expert, and so we would be happy to do that.
Okay, let's go for another question. Is there an explanation for why African American people are more at risk of dying from COVID-19 than white individuals?
So according to the study that was released this week in Wisconsin, what they said was, certainly access to care, both, access to medical care, access to mental health care, insurance coverage, and just some of the kind of inherent stigma and belief systems that, right now are so ingrained within our culture, and that really that fighting for social justice, what was displayed with that, I don't know. Dr. LeNoue, you as a medical doctor can answer any more from a medical perspective.
Absolutely. I'm not aware, and I'd have to look at the study again, but I'm not aware. I don't believe that there is any physiologic vulnerability or anything different within African Americans versus other individuals, but I think it goes back to the points that Dr. Maloney made.
Okay, next question. Is the goal over time to be able to come off of medications they said they can imagine that it varies case to case and substance to substance.
It's an excellent question, and the answer is, for individuals that I work with, is that it sort of depends. Yes, we always try to utilize the lowest effective dose of an approved medication as possible, and whenever it's appropriate and possible, we're always looking for opportunities to be able to, again, reduce the dose and or taper and come off of the medication altogether, if that is a mutually agreed upon decision. Now, ultimately, the decision always rests with that of the client, the patient, right? But it really, I think, comes down to trying to understand risk for relapse. And, rarely is there ever sort of concretely, like definitely a right or wrong answer. We will always take into account an individual's beliefs and their desires and their wishes, because that is really what drives treatment. But I think back to the point of risk, we have to think about what is the risk of an individual being on a medication, side effects, what have you, which is very important, right? What are the benefits of being on the medication? So we're looking at that. And then also, what are the potential harms, the potential risks and benefits of no longer being on the medication? And so when we look at that, we really just try to weigh and understand those factors, in addition to timing, because I think that timing and context is key. If someone's doing really well, they have a lot of stability, accountability, consistency in their life, minimal stressors, that would be an opportune time if an individual is wanting to consider trying to come down on the dose of a medication. Absolutely, we want to try it when and if that's appropriate. But I think that, again, context is key. And just like we wouldn't start a medication and ramp up a dose really quickly, it's not our practice. We also would not just stop a medication altogether unless there was, an urgent or acute clinical indication, right? Because we really want to provide scaffolding, and we want to try to pull that away, because it is a form of scaffolding and support to most effectively and gently and compassionately to provide care, and also making sure that that individual continues to see success and do well. Yeah. So those would be general strategies and approaches that we would want to consider whenever we're starting or potentially stopping a medication.
Thank you. Okay, the next one says, I've had clients being treated with methadone who were affected by their dose to the extent that they were unable to safely parent their children for much of the day. Is this level of dosage necessary? Are there likely other factors?
So thank you. Also a great question. I've worked with individuals who are on methadone, and I think we need to know more in that context too. Does that person, do they have comorbid medical issues that could be affecting their alertness and awareness? They may or may not. And so I think that the details are key, context is key. But if there are not co-occurring medical issues, I'm thinking about even like sleep apnea. If someone has, really bad sleep apnea, they're getting really poor quality sleep, they're not getting consistent oxygenation to their brain, that can certainly affect their alertness and awareness. Now, no doubt, if someone's on methadone, that may not be helping either. And so I think that really wanting to understand those factors, and again, the possible risks and benefits. But all things considered, we'll say hypothetically, other issues have been ruled out. There don't appear to be other factors coming into play. We definitely do not want any individual to be impaired, period, especially when they're treating or taking care of, a child. And then also when we think about driving too, those are all factors that we definitely talk to our patients and clients about, the risks, and also thinking about, making sure that they themselves are safe and that they're receiving safe, informed care, but that individuals around them are safe. So, for example, if someone, that I was working with, exhibited or reported symptoms such as that, we would definitely look at, are there complicating circumstances coming into play, and or looking at a dose reduction or possibly a change to a different medication.
Thank you. Let's see. I noticed Vivitrol was not mentioned in the PowerPoint, although I have seen it used in this area. Can you discuss?
Absolutely. So Vivitrol is the long-acting naltrexone that I had mentioned, and so we typically just stick to generic names. But Vivitrol is the brand name for the long-acting injectable form of naltrexone, and certainly, as noted, it has indications for both alcohol and opioid use disorders, and is quite effective and convenient, because I think that convenience is also really key when we think about helping individuals to achieve and maintain sobriety. And if if it's fitting and they're in agreement and they can go in once a month to get that injection and then not have to remember to take the medication on a daily basis, things like that. I mean, I think that is definitely an opportunity, and one that we'd want to explore when it's appropriate.
Okay. Next question. I would like to ask about the impact on dental health problems with Suboxone. I've had several clients who are having dental issues.
Also a great question. There can be issues, especially because with buprenorphine, the generic for Suboxone, the brand name. So there are tablets and films that are sublingual. So an individual holds those tablets or films under their tongue, and they're absorbed into the bloodstream sublingually or under the tongue. You're not supposed to swallow them, because it actually it's not very pleasant, and it also reduces the absorption of the medication into the bloodstream. And so metabolism is key here. It's really designed to be absorbed through that route, because we also have to think about how it's metabolized through the liver. And when it goes through the liver first, it can also reduce the bioavailability or the availability of the substance. So to the question and the point then of, can there be dental issues? There can be, but typically what we see clinically is that that there may be comorbid dental issues that could either be pre-existing and or concurrently coming up. So oftentimes if individuals have used substances that have either eroded or decreased dental health, or if there's poor dentition to begin with, it can certainly be a complicating factor. So certainly, again, kind of in one of my last slides, and thinking about treatment, thinking about dental health is certainly important, and thinking about physical health. And so wanting to get individuals plugged in with a dentist, with a primary care provider, and making sure that all of their medical, dental, mental health, substance treatment needs are all being addressed concurrently.
Dr. LeNoue, you had mentioned the long-acting naltrexone and the convenience behind that. There's also an injectable long-acting buprenorphine product with several more coming to market probably here in the very near future. I was wondering if you could speak a little bit about that, because certainly during COVID, that can become more convenient.
Thank you, Dr. Maloney. Yeah, it's an excellent point during COVID, and even to the individual's question about dental health, right? I mean, if there was a concern linked to Suboxone, buprenorphine for the sublingual formulation, you might think about, if it's appropriate, the injectable formulation that's long-acting that would not affect an individual's teeth. And then to Dr. Maloney's point, yes, this could be a really great option for individuals who have transportation issues, if there, are financial concerns. There's oftentimes, not necessarily in every case or circumstance, but there are oftentimes grants or waivers or other things that could be helpful with paying for, the medication. And so that could be something to be considered to help with the cost, but also to be able to provide consistent treatment and coverage, especially during these uncertain and stressful times. And so if we can try to eliminate a variable as far as like access to treatment or consistency, compliance with treatment. If as long as the individual's in agreement, if we can reduce or eliminate that factor so that they only have to go in once a month to be able to get that treatment, and they get 28, 30 days of consistent release of medication at appropriate dosing, and they're not starting, coming off, forgetting. I mean, it can be complicated, right? I think if we can do that, I think is a service that is an opportunity that we can provide to patients to help them in their treatment and recovery.
Okay, next question. What do you recommend treating a patient with drug, specifically weed, and alcohol addiction? The patient is motivated to begin alcohol treatment via AA 12-step.
Well, I think a combination of various types of therapy, if they're motivated, certainly looking at, CBT therapy in conjunction with increasing, recovery attendance at 12-step meetings, but really kind of continually enhancing that motivation, because many times we will see, an individual be motivated to stop using alcohol or want to become in recovery from alcohol, and yet want to still smoke marijuana. And so kind of looking at that motivation, how do those two trigger one another? And it may be a harm reduction approach initially to start with the alcohol, and then ultimately look to address the marijuana use as well. And then potentially looking at a prescription for naltrexone if appropriate, depending on cravings. And, Dr. LeNoue, I'll turn it over to you to say more about that.
Yeah, I totally agree with Dr. Maloney, and that, starting with motivational interviewing, looking for that engagement. And for alcohol use disorder, yes, looking at those FDA approved options that we discussed, including naltrexone, like Dr. Maloney mentioned. What you can see too is that with reducing use and dependence of one substance, it could certainly in turn positively affect the use of the other substance. Not in every case or situation, but we certainly do see that clinically, that it could be helpful in reducing other substance use. The harm reduction approach, absolutely, we're going to think about, because at the end of the day, while the goal may be trying to reduce and eliminate any and all substance use, I think that when we think about stages of change and helping individuals to be safe and healthy, we're not going to endorse using substances, but also we can recognize on the flip side too that reduced substance use, as long as we're continuing to move in a safe, positive, appropriate direction, that can be a win in this stage of change, right? If someone is, instead of drinking a full bottle of wine every day, if they've reduced it down to a half bottle, we're still working on engagement. Now they're down to a glass of wine a day. Yeah, of course we're going to be trying to aim for no, alcohol use at all. But I think that they're, like we talked about, like monitoring for success, that goes beyond even just, drug screen testing, but looking at the win. And I think that is a win as long as it is moving in a positive direction overall, and that we're aiming for overall recovery. Yeah.
And I think that really goes to, here in Wisconsin, we've seen an increase in the use of what's been termed goofballs, or, the combination between opioids and methamphetamine, and really trying to, engage our patients in that. And, we have a patient in treatment who, was able to get 3 days in recovery and then would relapse. And, our goal was to get to 10 days, of recovery. And that took some time, but, that's part of that process of really engaging the individual where they're at that moment, and working, certainly during these uncertain times with what that patient presented with at that time.
Okay, and we have time for one last question. CBD oils or other forms of CBDs be considered to assist a patient in looking to stop or curb marijuana use?
a great question. It's a loaded question. Dr. Maloney, would you like to start or would you like me to start?
You go ahead, Dr. LeNoue.
You know, this is a very hot topic, and I trained and worked in the state of Colorado for many years, and there's a lot of information. Well, number one, that's just not known about CBD, and so it is an area of hot research interest. And I think, hey, we need to research. We really need good quality randomized clinical control trials, that's safe and ethical. So we have to think about that too, especially when it comes to, the potential exposure of a medication or substance to an adolescent or developing brain. Overall, I think you can pretty safely make the argument in many ways that there is equally, if not more, that we don't know about CBD than what we do. CBD, cannabidiol, is one of over 100 different types of cannabinoids that we're aware of. There are probably more. Tetrahydrocannabinol, THC, is also a cannabinoid. It's the active ingredient that we think of in marijuana frequently. And so, CBD is different structurally, molecularly than THC. The reality, though, is that unless an individual is getting pharmaceutical grade CBD that is manufactured in a laboratory and is only dispensed and available through a pharmacy and through a hospital, for indications like Dravet syndrome or some really severe types of typically pediatric epilepsy, we don't see that there are evidence-based approved indications that are safe for CBD at this time. Could there be? There may be. Again, we need more research, no doubt. But we definitely don't want to put the cart before the horse when it comes to individuals, especially youth, because we know that youth are very keen on the use of CBD and different cannabinoids, especially when we think about their developing brain, the potential negative impact that has on synaptic pruning and brain development and memory and cognition. Not to mention, lastly, I'll just say that unless you're getting pharmaceutical grade, CBD that's going to come typically through an IV formulation, an individual is very, very likely getting THC and or other cannabinoids in that CBD product, even if it's labeled as CBD. So.
Yeah, and I think along with that, just from a psychosocial assessment, helping to understand that individual's motivation. I mean, it's not something I'm personally going to recommend to my patients, but helps again to understand where are they at, what is their belief system behind that, what is that providing for them, because, we found similar to vaping, it's been a hot topic. It's been something that they can connect with others about, particularly I found that like with some of social anxiety patients, it provides a hot topic, something that they can connect with others about when they're shy, and that sort of thing. So trying to also understand it from that psychosocial perspective.
One last very quick comment is I would just say too, when this comes up, because it frequently does in my clinical work, we just approach individuals and families with an open, non-judgmental, non-shaming approach, because we know at the end of the day, especially if individuals are using it to treat like anxiety or replace it, for other substance use, we definitely can respect that people are trying to do the best that they can in those circumstances to alleviate some sort of pain or suffering or anything else. So we're always going to try to meet them where they're at.
Okay, well, thank you again, Drs. LeNoue and Maloney, for taking time away from your clinical practice to share your valuable insights with us. And next week on Thursday, June 25th, we'll offer the final webinar in our weekly COVID-19 series. Dr. Joshua Nadeau and Dr. Jennifer Park will focus on how to treat symptoms of anxiety and depression among youth with autism spectrum disorder via telehealth during the COVID-19 pandemic. Keep an eye on your inbox for details and encourage your professional colleagues to register. I'd also like to let you all know that Rogers is here for those who are struggling with mental health or addiction, now potentially more than ever. We are continuing to accept patients in both inpatient and residential settings in Wisconsin. And we're very proud to offer Rogers Connect Care, our virtual option for those needing intensive outpatient levels of care. Based on recent decisions made in several states, we are starting to transition some of our partial and intensive outpatient care services back to the clinics using a hybrid model of on-site and virtual treatment. While these patients are physically in the clinic, they will continue using the same virtual treatment via Microsoft Teams while on site. So before we conclude, I'd like to ask our presenters to share their recommendations on additional resources for our participants.
Yeah, here they are. You can go to cdc.gov. Yep.
So that about wraps it up, everyone. I want to remind our participants that those of you who meet the required time commitment will be eligible for CE credits. About 30 minutes after this webinar ends, you will receive an email with a link to the mandatory evaluation form. And once you complete it, you may download your CE certificate for the event. We will have a recording of today's webinar and the slides available on our website at rogersbh.org. So on behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.